Alright, let's get started. Morning.
Good morning.
I left early.
Alright, let's turn to page 149, 149. Alright, yesterday we started the IV anesthetics, chapter 9, and so I'll backtrack just a second. We talked about what the drugs were, and they're listed here. Certainly propofol, etomidate are the two we use most commonly, and the others have niche uses, but they're important, and you will have a chance to give them. We went to page 151 and talked a lot about the kinetics. That is first and second column, what's the half-life of the drug, and when we speak generally about half-life, we're referring to the beta half-life of the drug or elimination half-life, because that's the one that really matters to us. And by definition, of course, half-life is the time it takes for the blood level to fall by 1/2. So 1 half-life after the drug is given, you will have eliminated 50%, 2 half-lives 75%, 3 half-lives 87.5%, 4 half-lives 93 and change, and then it'll soon be gone after that. So it takes about 4 half-lives to eliminate a drug out of the body. We talked about clearance, and that was really just a mathematical calculation. Didn't really matter to us. Obviously, clearance means how fast is the drug cleared out of the blood, but it's not something we worry about clinically. Volume of distribution is, of course, a very common concept, and that has to do with idealizing the human body inside and saying that it has X amount of water. In this case, it's 28 liters. And if you do it per kilo, then it's 0.6 liters per kilo. And then you can tell if a drug is limited to body water, then it'll have a volume of distribution 0.6 or lower. If the drug is more widely distributed in the body, past through the body water into tissues, then it tends to have a higher volume of distribution. And then finally, protein binding, and the fact that drugs bind to albumin and other glycoproteins, AAG being the most common, and supposedly changes in protein binding could affect the blood level of the drugs, but I don't think it's relevant, so there. The cutoff point is usually thought of as about 90%. So a drug like ketamine, you notice here, its protein binding is 12%. We wouldn't have to think about it. A drug like Valium, which is 98 or 99%, then that would be considered possible changes in people, changes in plasma proteins, or if you have drug interactions and more than one highly protein-bound drug. If anybody has any questions about any of that, I'll go through it again. I'd be glad to. On page 152, I more specifically mentioned the kinetics of propofol, which is very important to us because we do this every day, every case. We have to administer propofol and then consider where is it in the body, how many minutes after we give it, and so on and so forth. And initially, of course, it's given IV and then immediately distributes because of its high lipid solubility into the vital organs. So it peaks in the brain and the heart and so on. at about a minute, you can see on this diagram. And I could also say, I didn't mention this yesterday, I would eventually, probably. It peaks in the brain in 1 minute and also peaks in the heart. So you expect the biggest drop in blood pressure from administering propofol to somebody to be when? When it's peaking in the heart. And that would be about 1 minute after you give it. So you don't expect to give propofol and 10 minutes later the blood pressure is way down. If it is, then something's going on you better fix. But because it drops blood pressure, you expect the peak drop is going to be about a minute afterwards, because that's the peak when the levels are peaking in the heart. Okay, then it ends up in the muscle and fat eventually. And we went through the different parameters in that the onset is rapid, 10 to 15 seconds. The duration of action is about 8 to 15 minutes, depends on what dose you give. Higher the dose, the longer, a couple of minutes longer it'll last. So the duration's about 8 to 15 minutes. The single bolus if you don't turn on a drip. The half-life is about an hour in most books, and it takes about 4 hours to eliminate it out of the body. So those are the kinetic parameters with propofol. The reason people wake up quickly from the induction drugs, of course, is on the next page with my little drawings, and that is it redistributes from the brain off into peripheral sites, the muscle, the fat, etc. Even though it's still in the body, it's not in the brain, so you wake up. And then I think we left off with page 156, talking about the mechanism of action of most of the IV drugs, that being that propofol, etomidate, and our GABA mimetic. Benzodiazepines, of course, are GABA mimetic. That is, they stimulate the receptors, GABA receptors in the brain. They're inhibitory receptors. When they're stimulated, the chloride channel opens up. Chloride goes inside the cell. It becomes more electronegative, and therefore it's harder to get it to fire. So that's inhibited. So that's GABA mimetic. Ketamine is one of the exceptions, and ketamine blocks excitatory glutamate receptors in the brain called NMDA receptors, and that's how it produces its actions. And then I think that's where I left off. So there's no and then. So the next thing, the last thing, if we go to page 158, there are the benzos, propofol, and etomidate are GABA mimetic. Ketamine is an antagonist at those first three classes of drugs, or drugs themselves, are agonists. They stimulate depression. Ketamine is an antagonist. It blocks an excitatory receptor, the glutamate receptor. Then finally, dexmedetomidine, which is where I left off. I didn't get that far yet. It acts as a presynaptic alpha-2 agonist. So it's sympatholytic. So let me explain that, because it's a little weird. All right? So here I go. We didn't get to this. Yeah, this is where we left off. Now, remember this drawing. I'm going to go on the camera and point. This is on page 50 in your book. You don't have to turn to it. You remember this from the last test, right? Sympathetic, parasympathetic. Oop. Sorry. And the different sites and receptors, transmitters, etc. Well, what I'm going to do is take this site right here, that is the postganglionic sympathetic site, and I'm going to blow it up and put it on the camera here. And let's make that bigger. All right, so this is the postganglionic sympathetic site, which we know is the neurotransmitter, is norepinephrine, and the receptors that recognize the release of norepinephrine are called adrenergic receptors. It's written in the yellow here. And so when you really get a sympathetic response, release catecholamines, release norepinephrine, it attaches to catecholamine receptors or adrenergic receptors, and you get a sympathetic response. So we've been through that a million times, right? So here's what happens. You get a sympathetic response by stimulating an alpha, a beta, or I'll put a D, dopamine receptor, on the tissue that you're trying to stimulate. Heart, lungs, the liver, the kidneys, whatever. All the receptors have automatically, if you see a receptor on a tissue, like an alpha receptor, if you stimulate this alpha receptor, release norepinephrine or give an alpha drug that stimulates that receptor, you're going to get a sympathomimetic response. Does everybody buy that? It's true. Now, automatically, the body's set up that you also, the norepinephrine that's released out of this package here, is norepinephrine, CNE, it's released. It also feeds back to a presynaptic alpha receptor on the nerve that released it. So when you have a nerve squirting norepinephrine out, yes, you're getting the response in the tissue, but you also neurotransmitters always feed back and stimulate a second alpha receptor, if it's a beta receptor, if it's a dopamine receptor, a histamine receptor, it doesn't matter. All receptors have this. And they're presynaptic receptors, and what they do is they're called autoreceptors, AUTO, autoreceptors. And they're there as a negative feedback system for the release of the transmitter. In other words, just look at it this way. Norepinephrine is getting squirted out, and the amount that's getting squirted out is going to depend on the strength of the action potential that's coming down the nerve, how strong you want to signal, how much catecholamine you want to release. But one of the ways that it fine-tunes how much norepi is coming out is it has to have some way to sense how much norepinephrine is in the synapse. So the norepinephrine in the synapse here stimulates the receptor, of course, but it also goes back and stimulates this autoreceptor, and it's a feedback control. So it tells the nerve, okay, there's a lot of norepinephrine here, out here in the synapse, don't squirt anymore. It's a negative feedback. Don't squirt anymore. So the nerve knows that, yes, it's got a lot of norepi out there, the message is being sent, and it's time to slow down the release. It's a way to kind of fine-tune what goes on. So autoreceptors are presynaptic receptors that match the postsynaptic one, and their job is to tell the nerve whether to continue, increase, or decrease the neurotransmitter release. So, if somebody says that a drug is an alpha agonist, it's stimulating alpha receptors, you have to know, is it a postsynaptic alpha agonist? Is it doing this receptor here in the tissue? Because that's going to be sympathomimetic. Or is it stimulating this autoreceptor, the presynaptic alpha-2 receptor? Oh, by the way, I didn't mention, it's Friday. All these are given the number 2. So if you have an alpha receptor somewhere in the tissue, there's an alpha-2 receptor on the nerve. If you have a histamine receptor in the tissue, you've got a histamine 2 receptor on the nerve. They're just by agreement. Somebody sat in a room and decided they're going to number them all with the number 2. Right, I wish they didn't. It's confusing sometimes. We'll get into that next semester. Nonetheless, I didn't make it up. That's what they decided. So this is called an alpha-2 receptor. presynaptic, alpha 2. And its job is to tell the nerve to quit releasing norepinephrine. If you decrease the amount of norepinephrine released, is that going to be sympathoglytic or lytic? Lytic, right? So you're going to decrease sympathetic output. Make sense? All right. Cool. So go to page 158, and there's dexmedetomidine or Precedex, and what does it say its mechanism is? It acts as a presynaptic alpha 2 agonist. So Precedex comes in, its site of action is here, right here, on the nerves. It causes the nerves to release less norepinephrine. Therefore, it's sympatholytic. What does it do? It makes you sleepy, it drops your blood pressure, it, has a depressant effect. Even though it's a sympathetic drug, you'd say, well, gee, it's acting on alpha receptors. That seems like it would be causing sympathetic stimulation. But the key is it presynaptic or postsynaptic? And if it's presynaptic, then it's sympatholytic. All right, is everybody with me on that? Take a look at the next page. Page 159. This was, I don't know what book, I can't remember where I got it from, but this was somebody talking about presynaptic alpha receptors, alpha 2 receptors, and you can see that, what they're trying to show is just drawing it a little differently than the nice color figure I did the last time. This is page 159. They're showing a norepinephrine containing neuron. It's releasing norepinephrine, and some of the norepinephrine is feeding back to the alpha 2 receptors. See, this is alpha 2 sub A, and that's causing negative feedback for further release of norepinephrine. That's what they're trying to show here. There's an epinephrine containing neuron. It's probably in the brain. It's releasing epi. It feeds back to alpha 2. Alpha 2s are negative feedback. So it's sympatholytic. Okay? What does it say on the page? Physiologic functions of alpha 2 adrenergic receptor subtypes, and if it's alpha 2, it doesn't matter, it's A, B, or C, I don't care, but it's an alpha 2 presynaptic feedback inhibition of norepinephrine release. The second bullet on page 159, therefore it's going to cause hypotension, analgesia, sedation, and it has some anti-seizure effects we'll talk about later. Yes?
So each alpha 2 receptor can either continue, increase, or decrease. So if it increases, it could act as sympathoglytic?
Yes. If you, and that's a good question. If you can have alpha 2, here's my drawing. You can have alpha 2 receptors here. There are alpha 2 receptors in the tissues. They're sympathomimetic. But the only way you're going to know that is they have to tell you that's postsynaptic alpha 2 receptor. If it's a presynaptic alpha 2 receptor, then it's here, then it's sympatholytic. All right? That's a good question because some drugs, like phenylephrine, is a classic alpha agonist, and it's an alpha 1 and alpha 2 agonist. So both in tissues, in blood vessels, there's both alpha 1 and alpha 2 receptors in the blood vessel, and they're sympathomimetic. They cause vasoconstriction. There's alpha 2 presynaptics also, and that inhibits norepinephrine release. Does that make sense?
Yeah.
Can you have an alpha 2 presynaptic antagonist that would continue allowing norepinephrine to be
Yes. Oh, yes.
released?
Benzodiazepine is a drug that's an alpha blocker. Phentolamine or registine is another one. And if you give them, then they go here and block this, and so they enhance norepinephrine release.
So that's sympathomimetic as well.
Well, it can be, but what happens is they also block the receptor here.
Oh,
So even though you get norepinephrine, they're alpha blockers, but even though you get more norepinephrine release, it doesn't go to the receptor because you blocked it with the drug.
so the drug does not differentiate between which alpha 2, it works presynaptic and postsynaptic?
Some do and some don't.
Okay.
The alpha blockers that we use, for the most part, are alpha postsynaptic. Alpha blockers are not widely used anymore. They use them for pheochromocytoma, when they take out norepinephrine tumors, and otherwise they use it to shrink prostates in old guys who can't pee. So some of the prostate drugs are alpha 2 drugs, and they mostly work here, but you will get some blockade in the presynaptic tube.
Does Precedex have any postsynaptic action really?
No, it's all presynaptic. So Precedex is an agonist. It's all presynaptic. So actually, I shouldn't say that. If you give a very fast loading dose of Precedex, then sometimes before you get the decrease in norepinephrine, you can get some stimulation postsynaptically. But it's transient. It's about 5 minutes when you first turn it on. They say that sometimes when you first turn it on, you can get a little bit of increased blood pressure, and then as soon as it kicks in presynaptically, it all goes down. We'll see. We'll talk about that tomorrow, next time.
If you have a patient that's on like a Evo drip
Yeah.
and you have them on a Precedex infusion too, are you kind of like fighting against yourself then?
Kind of. Yeah. If you got a Levophed drip giving norepinephrine, then it's mostly working postsynaptic. So the Precedex is working presynaptic. So, but there's some spillover. Nothing's pure. So a little bit. You're working a little bit, but it still works. Just made it a little higher doses and stuff. But it's that shows you the complexity of trying to drip 9 drips at the same time. And which we do. Sometimes you have to. But yeah. Okay, so to summarize, back to the previous page, I'll say it one last time, page 158, and that is the benzodiazepines, propofol, and etomidate work because they're GABA mimetic. Ketamine is an antagonist of NMDA receptors, glutamate receptors, and dexmedetomidine is a presynaptic alpha 2 agonist, which produces a sympatholytic effect. And that's the mechanism for all the induction agents. Any questions? Good. All right, let's go to page 160. I'm going to spend just a few minutes, go through a little bit of benzodiazepine discussion, and starting with this page 160. In fact, I'll go in the camera. Oh, I'll make it smaller. So let me just tell you the story. Don't write. I mentioned yesterday, late 60s, very famous pharmacologist now, he's dead. They all get famous when they're dead. He discovered or synthesized the first benzodiazepines, worked for Hoffman LaRoche Pharmaceuticals in New Jersey, and it became revolutionary in the world of sedation. Librium and Valium were the first two introduced. And with the introduction of Valium, it was extremely safe compared to the barbs, as I mentioned yesterday, and they took over the world, and still to this day, one of the top classes of drugs that are prescribed are benzodiazepines, because a lot of people are nervous, and they like their anti-anxiety drugs. And as I said, the nice thing about them is, first of all, they're fairly mild, and but they do produce a nice anti-anxiety effect, and you get tolerant to the sedative effect, so you can go about your business, have a life, and not walk around drowsy all the time, and still retain a very nice anti-anxiety effect. The second thing is if you bump the dose of them, any of them up a little higher, they have a quote, hypnotic effect. In pharmacology, hypnotic means they're sleeping pills. So they're called sedative hypnotics because in lower doses, you can give them IV for sedation like we do. That's what we get Versed for. If you use them chronically, then they'll get tolerance to the sedation. We don't do that, but somebody who gets a prescription and takes pills from the doctor would. And if you use them in higher doses, you can get a sleeping pill or sleeping effect that almost nobody uses them anymore because there's better drugs nowadays. But nonetheless, he introduced Librium and Valium, and then in rapid succession over the next 10 or 15 years, everybody and their grandmother, every drug company in the world wanted to come out with their own version, so they all synthesized some type of benzodiazepine and put it out on the market. And in the drug world, they call them Me Too drugs. Hey, me too, I want one of those drugs that's making you $1 billion. So a lot of Me Too drugs came out, and to this day, and I'll show you in a second, there's still over 20 of them on the market, and they are extremely widely prescribed still for both anti-anxiety and for sleep in some degree. Now, the thing about what these are called is first generation benzodiazepines. So let me show you this. I'm not going to have you know this. All right? I just want to show it to you, and then we're going to go on and never look at it again. The benzodiazepine drugs all have this 3 benzene ring. So they have this 3-ring structure. Anything with this 3-ring structure is called a benzodiazepine ring. The different ones, they just put different little attachments on the outside. What happened is, let's start with up here in the right line camera. Chloridazed epoxide, which is Librium. Now, Librium is rarely used nowadays. It's pretty much used to treat DTs, withdrawal from alcohol. But other than that, it's because it causes too much ataxia. You get wobbly on your feet, you can't walk, so therefore, what good is it? But alcoholics withdrawing, DTs are not walking around. So anyways, here's Librium. Well, Librium is converted in the body by acid hydrolysis to a couple of steps, and then one of the things it becomes is this metabolite in the middle called desmethyldiazepam. Des in chemistry means removed or without, take away. So desmethyl means you took a methyl group off it somewhere and it became something else. In this case, it became Valium. See, this is Valium up here, and its major pathway for metabolism is to remove this methyl group, and it becomes desmethyldiazepam. So guess what? Whether you took Librium or Valium, they both end up being the same drug inside the body. Desmethyldiazepam. Desmethyldiazepam has a half-life of 7 days, and it's active, just almost as active as the parent drug. So I could give you 10 milligrams of Valium, and 28 days later I could find some in your body. 1 dose. So that's, who wants that? Now if you're taking it chronically at home, maybe that's a good thing. You want it to last a long time. But for people like us, we want the drugs in and out. We want them out an hour ago. It's never fast enough for us. So that was a problem. Now here's temazepam or Restoril. At one time was the #1 sleeping pill in the United States, maybe 10 years ago or so. And you can see some of that's converted to desmethyldiazepam. Here's another one, Prazepam Centrax. They give it to old people. That's converted. So I mean, you can see there's all interconversion. One becomes another one. Desmethyldiazepam, when it's metabolized, is metabolized into oxazepam, which is Cerax. It's another prescription drug. So, I mean, it's just endless. So the problem was, to get to the end of the story, the benzodiazepines have great pharmacology. They're anti-anxiety, they're anti-seizure drugs, they're good for treating seizures. They are very mild, they have very little side effects, no blood pressure, heart rate problems, respiratory depression is really not a problem in regular doses. So they have all those nice effects. They got lousy kinetics. The pharmacokinetics stink because you just metabolize them into another one, and it's very complex. So what happened is they came out with what they call second generation benzodiazepines, and that, for example, this is Ativan, lorazepam here, and what they did with this is they put a hydroxyl group here so that it could be conjugated. Remember what conjugation is? You stick a glucose on there and pee it out. So here, see, this is metabolized as lorazepam glucuronide. So you didn't have to worry about metabolizing the Ativan. All you got to do is put sugar, here's a sugar molecule right here, stuck it on there, and peed it out. So lorazepam was a lot better metabolism. It was called second generation. Half-life was much, much shorter. And it's a pretty popular drug still for very limited uses, but it's still around. But it still didn't solve the main problem. They came out with what are called third generation benzodiazepines, and that's Versed. Versed is the third generation. And Versed is unique in that it's buffered in the vial to an acid pH, so that in the vial it would be in one shape, and then when you inject it in the body, the pH 7.4, it changes shape and kind of metabolizes itself. Or it's metabolized faster, I should say. So Versed has a half-life of about 2 hours. So I can tell you, here we were in anesthesia, we're using Valium. We used to use it on almost everybody. We give a lot of people Valium and fentanyl, or Valium and morphine. That was a common anesthetic. And this Hoffman LaRoche came by and said, well, I got another drug that does exactly the same, and instead of a half-life of 37 hours, it has a half-life of 2 hours. Would you like to try it? Well, hello. So, Versed, I think, in the fastest 24-hour sale I've ever seen, the entire anesthesia community all over the world switched from Valium to Versed. And we still to this day use it because it's got great pharmacology. And now we don't have to worry so much about the kinetics. With a half-life of 2 hours, that's pretty standard. It's gone out of the body in 8 hours. Well, we can live with that. And that's where we stand. Okay? So all this crazy kinetics used to be an issue. It's not so much an issue now. So take a look at the next page, page 161. And this I took out of the New England Journal this year. They were talking about treatment of benzodiazepine dependence, because some people do get dependent. Not supposed to say addiction anymore, it's drug dependence. They become addicted. What happened is this: they used to think for many years, through the 80s and 90s and so on, that you couldn't become dependent on the benzodiazepines because everybody was taking Valium and all those. What happens is, if you stop taking them, it took 30 days to get it out of your body, so you had a withdrawal reaction, but it didn't last until next month. By then, they weren't seeing the doctor anymore, and so people weren't noticing that they were having drug withdrawal because it was delayed for the fact that it took so long to get rid of the drug out of the body. So finally we realized, of course, that it can cause withdrawal. It's not life-threatening. It's more just like you feel anxious, and it's kind of a feelings thing rather than a physical thing. But you can get dependent to benzodiazepines, and the FDA cautions physicians they would like them to limit the duration of prescriptions to these. If somebody comes to you with an anxiety problem and you decide to prescribe one of these, They say limit to about 3 months, time, then reassess, try to get them off it, or, did you divorce your husband and get rid of him so now you're not anxious anymore? Or whatever, did you get rid of the anxiety-producing issue in your life, so now you don't need drugs or whatever? It's, I don't know. But anyways, you can see this is from 2017, a couple months ago, so these are the current ones. And they're saying hypnotic agents, long half-life, and who's going to use, look at the half-life of flurazepam, was about, the substance half-life was 2 to 3, this active metabolite half-life was 100 hours. Are you going to take a sleeping pill that lasts 100 hours? Come on. So, I mean, that's just, it's not going to happen. Shorter half-life ones are listed there, but they're still too long. Because when you have a sleeping pill, you want it to work right away and put someone to sleep, and then you want it to go away so they can wake up the next morning and actually open their eyes, walk to the bathroom without falling over, and drive their car to work, and so on. So sleeping pills, you have to have them work fast and short, and these don't. The anxiolytic agents, of course, there's all the benzodiazepines, and there's some shorter ones there, and these will be used because they're given by prescription to treat anxiety. You go on the next page, and there's the different structures. You notice they all have that basic three-ring structure, and then different groups around the outside make all the different benzodiazepines. There's Valium, Ativan, Versed, Temazepam. Remimazolam is an experimental drug that's going through clinical trials right now for anesthesia. And what this is an IV infusion Versed. It's a chemical analog. They altered the Versed molecule a little bit so that it's metabolized in about 2-3 minutes. So you have to give it by continuous infusion. When you turn the infusion off, 2 or 3 minutes later, it's all gone. Well, isn't that going to be ideal for anesthesia? You think we'll like that? Oh yeah, I think so. So maybe it'll get to the market, maybe it won't, but it's going through clinical trial right now. Yes?
If they all have the same metabolite, how do some of them produce hypnotic properties and others produce only
Dose.
anxiolytic properties?
Dose.
Dose.
It's just dose. In the lowest doses, they're anti-anxiety. If you don't bump the dose up a little higher, they're sedative. If you bump the dose even higher, they're hypnotic. So it's just a matter of dose. They would all do the same thing. Then there's flumazenil on the bottom right, and that's an antagonist. That's just a benzodiazepine, but the groups on the outside are structured to make it block the receptor rather than stimulate it. Flumazenil reverses the other ones, and we'll talk about that next week. There's kind of the basic structures. On the next page, page 163, this is from my textbook, I think. I probably made this table. Benzodiazepines that are currently used in the United States, and there's the generic names, the trade names. Many of these drugs you're ultimately familiar with. Patients take them. They're all over the place, so they're very commonly used drugs. And any benzodiazepine table, you notice all they do is put the half-life in there, because they're all the same otherwise. You just want to know how long it's going to be sticking around. So notice there's just half-lives. Look at midazolam or Versed. Half-life is what? 1.7 to 2.6 hours. So it's around 2 hours. And that's good. It's pretty short. And it's used as an anxiolytic drug and so on and so forth. Sedation, induction, maintenance of anesthesia. Now, they're still used, as I said, very prominently for anti-anxiety reasons. They can be used as sedatives. As I mentioned, Librium's used to sedate people in DTs. We give Versed to sedate people. That's what we do almost every patient. But they're not used as much for sleeping pills because they just last too long. But there now is a second group of drugs called non-benzodiazepine receptor agonists. They work on GABA receptors, but not at the benzodiazepine attachment point. but they work somewhere else. And they're probably the most commonly used drugs now. They're GABA-mimetic. A lot of slang literature in the drug world call them the Z drugs because of their generic name starts with Z. But Ambien, of course, I think is probably one of the most common. And, they're used because they have very, very short durations. You can go to sleep and then the next morning supposedly wake up refreshed. Not really, but almost. It's better than the benzodiazepines. And then they now have a new one out, Restora. I see it advertised on TV, and then when I'm watching football games all the time, I don't know, football fans have a lot of sleep problems, but and it works by blocking orexin receptors. And orexin receptors are very interesting. I'm not going to cover them, but they are interesting because they make you wake up. They're wake-up receptors. And there is a lot of research in anesthesia nowadays that when you, during emergence, when we're waking people up, we always consider it to be just a passive thing. You blow off the anesthetic, and when the anesthetic's gone, you wake up, and you go home, and everybody's happy. But there's now some evidence that during emergence, what happens is your brain releases orexins, and the orexins help wake you up. They're stimulatory, excitatory receptors in the sleep-wake centers in the brain. So I get off on a tangent there. Sorry. But these drugs, they call them the DORAs, D-O-R-A's. They're the dual orexin receptor antagonists, and the DORAs block orexin receptors, so they can't wake you up. So they make you go to sleep. And there's the one there, like I said, Restora, becoming very popular because it's relatively safe. So. Okay, that's enough of that. Any questions about any of that?
Just kind of a random question, are there orexin receptor agonists?
Yes, there are. They're not. There's one in clinical trials for being treated for narcolepsy. So they're hoping that it'll be work well enough to be able to treat narcoleptic patients. So yes, there's research on both the antagonists and the agonists. Because for narcolepsy, the only other thing is amphetamines, and they're lousy. They work well, but they got so many. The cost is too high. So these are hopefully going to wake you up without having to suffer the fact that you're going to be a speed addict, which is you're awake, but now nobody wants you in there. Okay. Any other questions? Let's take a break. All right, let's get started again. I want to turn to page 164. Page 164. And let me just mention quickly, Clinton reminded me that we're having some difficulties with the vodcast from last Friday. Each of the classes is turned into a vodcast. A lot of people are downloading them. You can stream it, and it works fine. But if you want to download it and have it on some other device, we've been doing that for every class too. But last Friday somehow got corrupted. We're having difficulty making it into a vodcast. We've sent it off to MediaSite in Wisconsin, and they're seeing what they can do with it. So if you're trying to find last Friday's, you can watch it online. That's no problem. But otherwise, we'll see. We're trying to get it fixed. Okay, page 164. Pharmaceutics. So let's go over the pharmaceutics of these drugs because it's important in a clinical sense. And so let's go through some of this stuff. Page 164. This is pharmaceutical preparations of the IV anesthetics. Remember, pharmaceutics is how do you make the drug, it's how it's packaged and made and prepared, etc. So, starting with benzodiazepines, Valium, because it is so lipid soluble, it has to be put into some solvents to get it to dissolve into an IV preparation. You can see that it's in 0.5%, 40% propylene glycol, 10% alcohol to get it to solubilize and become a liquid so you can inject it. Therefore, you have it hurts. It has a lot of pain on injection because of the vehicle, the soup it's prepared in. It's got alcohol and propylene glycol and all the rest of that stuff. Valium, Ativan, I'm sorry, is a little bit better, but it still has 0.4% propylene glycol, so there's a little bit of pain on injection, but it's minimal. And then Versed is not, it doesn't cause pain on injection because it's an aqueous solution. So what they do is Versed is a base, and in the vial they buffer it to a pH of 3.5. So it's a basic drug in an acid solution. It becomes ionized, it dissolves in the vehicle. When you inject it, it goes back to 7.4 and then it works. So you don't have to put a lot of solvents or incipients, they call them, into the drugs. So there's no pain on injection. Etomidate, again, because these drugs are so lipid soluble, it's water soluble at acidic pH, so it's buffered to a pH of 5, and then it dissolves a little bit better. There is some propylene glycol solvent in it as well, so it does burn on injection. The next one is propofol, and now we got to talk about this. So let's stop for a minute and talk about propofol. As you know, because you've all given it a million times, propofol comes in a lipid emulsion, milk-like solution. When it first came out in the late 90s, well, it was used in Europe for a while, and they had a different preparation. They had what was called Cremophor. But a lot of people were having allergic reactions to the vehicle that it was in. So the American companies came up with that lipid emulsion, the milk solution. And they marketed propofol, and when it first came out, it was extremely expensive because the preparation of it is so fussy. And so we, being filthy practitioners and cheap, it's a bad combination, would take propofol, draw it up, and then if we didn't use it, we'd save it overnight and use it the next day. So people had infusion pumps, and they'd have like a 50 ml syringe full of propofol, and maybe they only use 15 mLs, so they just save it, and they change the tubing the next morning and use it on the next patient, and use it on the next patient, and so on. And there was a lot of that going on, and there was a lot of drawing in a syringe, and if you didn't use the syringe, you just leave it on your cart and go back to work the next day and use it, and so on. You can imagine that this lipid emulsion is a tremendously wonderful petri dish for growing bacteria. And in fact, we did grow bacteria and injected it, and there was a couple of deaths. Some young, healthy people. I guess one of the girls was a teenager. ASA1, going for a routine procedure, was injected with propofol that sat on a cart for 2 or 3 days. Had become infected. Solution of it, the milk, and she got septic and died. It was very tragic. So, needless to say, letters went out to all of us at home about handling it, and the FDA got all involved. And they had a similar case in Las Vegas. I don't know if it's still under litigation, where several people got hepatitis, because the propofol was contaminated. and they use the same propofol on about 30 different patients, the same fusion pump. So needless to say, it was bad practice. It shouldn't have happened. It was our fault. So the hospitals and the FDA and so on did a couple of things. Number one, they said, well, many hospitals said, why don't we have the pharmacists draw the drugs up under laminar air conditions. In the pharmacy, they have those hoods where you can draw the drug up in a sterile manner. And besides, the pharmacist will actually do it correctly, unlike us. We just do whatever we got to do. And secondly, let's say that if you don't use it within 6 hours of drawing it up, then you need to discard it and throw it away. And if you don't use all of it for that particular patient, throw it away. Don't use it on the next patient. I mean, it seems simple. It's basic nursing care. We don't use the same needles. A lot of anesthesia people thought, well, the needle doesn't really go in the patient. It's just sitting in the IV tubing, so it doesn't really get contaminated. So they just use the same needle in the next IV tubing and the next IV tubing. And again, I'm not justifying it. It's just stupid. But nonetheless, people did it. And to this day, many hospitals you go to, you're not going to have to draw up, and of course, when the pharmacist started drawing the drugs out, the anesthesia people went, oh, that's kind of nice. You don't have to go to work in the morning and draw all these drugs out. So they let the pharmacy make a tray for us, and they deliver them up in the OR in the morning, and everybody gets a tray in their room, and it's all the drugs are drawn up for them, labeled properly, which we don't do either, and so on. So, jumping up to 2017, we've had some bad experiences, mostly our fault, because of bad handling of the drugs and administering the drugs and so on. Because of the vehicle of propofol and the fact that it can very easily grow bacteria, become contaminated, and then you can make the patient contaminated. So it's not a good thing to not handle it properly. And as I said, we never, and now it's generic and it's not as expensive, although it's still fairly costly. We would never use the propofol on more than one patient that we drew up. If we don't use whatever we use, we discard it, and there's a whole procedure for that. And I think a lot of this is going to be moot, because I know some of you have already experienced or are doing this, is doing the little scanner. The drug's going to have a scanner bar on it. You're going to scan it for the patient, and you get a new one. I mean, they do that on the floors now, and I think they're coming into some ORs already have them, and I think it's going to be a routine any time now. In your lives, since you're new, you're going to have that as routine practice. When you go to give a drug to a patient, you're going to be scanning a bar in some scanner, and then mostly because they want a bill, but it's also it's the right drug to the right patient at the right time, and so on and so forth. So there is a drug safety issue that has always been around with propofol, because it's so lipid soluble you can't get it into solution. This is the only way that they could get it into solution, was to make it this lipid emulsion solution. Now, take a look at page 164. There's propofol. The trade name is Dexmedetomidine. So Astra Pharmaceuticals, AstraZeneca, that originally brought it into the United States, they called their trade product the name Diprivan. All right, and over the years they've changed the formulation a little bit, but essentially it's a 1% solution. You know that, 10 milligrams per ml, and it contains 10% soybean oil, 2.25% glycerol, and 1.2% egg phosphatide. EDTA is a preservative, and that's put in there as well. The pKa is 11, and so when you inject it, it changes pH, and so on and so forth. And that's what makes it a milk solution. Now, what happened is, we've been having shortages of all kinds of drugs, and you know that, and you've been living with that in your critical care practice and so on. And one of the critical shortages over the years has been propofol, and on occasion we go through this propofol shortage. needless to say, it's pretty hard on us because we pretty much can't function without propofol these days, or at least we seemingly can't. And so the FDA let the European and South American and Australia, all the other companies bring propofol in the United States as a generic drug, and it has different formulation. And the generic formulations have sulfites in them. They have sulfites in them as a preservative. And patients can be allergic to sulfites. The one group of patients you worry about are asthmatics. Many asthmatics have a cross allergy to sulfites. Now, most people are exposed to sulfites in food, red wine, and certain. You go to a salad bar, and you know they don't want everything turning brown, so they spray sulfites on it to make it look nice and so on. Did you ever have one of those? They bring them to us once in a while. Somebody sends a thank you, and they send one of those fruit things in the sticks, and they look like a little basket, and they're all in that thing. Well, Sandra and I were there. We left it on the table in the kitchen. 2 days later, it didn't turn brown. It still was fresh looking. And I'm thinking, I don't know. There's pineapples and apples and all kinds of fruit, and it looks like the day you took it out for like 3 days after you open it up. Don't put it in the refrigerator. I'm not sure what they spray that with, but maybe if I take enough of it, I'll live longer. So anyways, here's the point. You have to, I would say most anesthesia departments nowadays use generic propofol. And most of the generic propofol formulations, and it's hard for me to make a blanket statement because so many different countries are supplying us nowadays, but most of the generic formulations have sulfites in them. What the companies are doing, fortunately, is they write right on the vial, contains sulfites. So that's kind of nice. And if you take the time to read the vial, hopefully you do, when you drop a drug, then you'll note that it has sulfites. So the whole point of this discussion is, well, I got some more, but one of the big points is that if a patient is asthmatic, then we preferentially give them Diprivan. All anesthesia departments will have both, generic, and they'll have the trade product Diprivan available. Maybe not in the same drawer, maybe you have to go to the workroom. I don't know, every department's different. But if somebody's asthmatic, you don't want to give them something with sulfites in it. That's a given. And the one without sulfites is the Diprivan brand product by AstraZeneca. Generics will have sulfites, but it'll say on the bottle. So it's easy enough to figure out. Question?
You have a facility where pharmacy pre-draws your propofol, and what do they say then sulfite?
You'd have to ask. You're going to have to call pharmacy and ask. If they pre-draw it, they usually send a vial up with it, though. So you have some extra vials. But otherwise, you're going to have to ask the pharmacy. Okay, now, let's take a minute and take a look at page 165. And I want to kind of go through this a little bit. To show you this, it's kind of weird. Right? This is from an article from British Anesthesia Journal, Pharmaceutics for the Anesthetist, and this is page 165, recent reformulations of propofol. So propofol is initially manufactured as a preservative-free product, and in some countries, such as Australia, this is still the case. However, as the use of the drug increased, reports of bacterial contamination of propofol emulsion started to appear. In some cases, the post-op infection have been due to the contaminated product. The concern the preservative-free product could easily be contaminated through handling led the original patent holder, AstraZeneca, to reformulate the preparation. So it has antimicrobial substance called EDTA that's in a lot of drugs, and a concentration of 0.005%, and that successfully retards microbial growth. About the same time as EDTA was being put in propofol by AstraZeneca, another manufacturer marketed a sulfite-containing product. This product contains sodium metabisulfite and is formulated in a little slightly acidic property. The release of these products has initiated a number of studies examining whether the new additives might have any effect on stability, and they don't seem to. While propofol dimer is found in all trace amounts, sometimes the sulfite can be a little yellow discoloration, as they mentioned. If it looks funny, throw it away and get new stuff. I mean, basically, that's true of any drug. Interestingly, the last sentence, both products are promoted by their respective manufacturers as being preservative-free. Since the concentration of both EDTA and sodium metabisulfite are below what the USP minimum standard is, so they don't have to put it on the label. But generic companies do it as with the sulfites, they've agreed to do it so that we know if it has sulfites in it or not. Right. Okay, now what about allergy? That's a question that always comes up. If you're allergic to soy, if you're allergic to dairy products, this has got eggs in it, supposedly, right? If you're allergic to have an egg allergy or dairy allergy, are you contraindicated or allergic to propofol? So let's take a look. Page 165 on the bottom. Propofol lipid formulation has been scrutinized because of the lecithin content. Lecithin means egg yolk. It's a phospholipid compound composed of a range of chemicals. These are combined with various amounts of triglycerides and fatty acids. It was originally obtained from eggs, although now soybeans and other vegetables with high lecithin content are also used. So they don't even use eggs anymore to get the egg phosphatide. They just get it from soybeans. It's good for vegans, I guess. Controversy exists whether propofol should be avoided in patients who are allergic to eggs, soy, or peanuts. So if somebody has a peanut allergy, can you not give them propofol? Because it might have some peanut products in it, see? It's not easy going to work anymore, is it? Warning labels differ. I'm sorry. Egg allergy is the most common in children and usually is outgrown by adulthood. So usually in the early teens, you outgrow egg allergies and you're fine. The 2009 guidelines published by the Brits and the Irish authorities claim there's no evidence that propofol should be avoided in the egg or soy allergic patients. The warning labels differ among countries for the same formulation of propofol supplied by the same company. So some company manufactures it, and depending on what country they're sending it to, it might say avoided in allergic egg allergy, in the other country it doesn't say that. That's the same stupid product. I don't know, go figure. The product formulation for Diprivan warns of its use in egg or soy allergic patients in Australia, but not egg in the UK, and lists no food allergies in the United States. This is despite all three formulations being supplied by the same company, and so there you go. And they've done studies with people who are allergic to peanuts and soy and eggs, and I list a couple there. And going on to the next page, soy allergy is it's common early onset food allergy in children. Many children outgrow the allergy by age 7. Refined soy oil of the type used in propofol have had the allergenic proteins removed during refining. Therefore, it's safe in patients with soy allergy. The suggestion that peanut allergic patients may exhibit propofol allergy is only due to cross-reactivity between these plants. Therefore, like soy allergy, there's no data showing there's any problem in a peanut allergy patient. So, I would make the conclusion that it's safe to give propofol to somebody with an egg allergy because they don't use eggs in it anymore, with a soy allergy or a peanut allergy because they remove the proteins that you get the allergic reaction to during refining. Okay? So let's take a look. This is from the British Journal of Finally on page 166 on the bottom. This is from the British Journal of Anesthesia 2016, last year. There's no evidence for contraindication for the use of propofol in adults allergic to egg, soy, or peanuts. Background. Propofol is thought to be a potential cause of allergic reactions in the patients who have these allergies. However, other than 6 case reports lacking any evidence, there's no evidence linking these two types. Conclusion. There's no connection between the allergy to propofol and allergy to egg, soy, or peanut. The present practice of choosing alternatives to propofol in patients with this kind of food allergy is not evidence-based and should be reconsidered. In other words, put them to sleep with propofol. Don't worry about it. Even though some labeling is going to say, you know, depending on who made the thing and what country they sent it to, Lord only knows what they're writing on a label. So it's all very confusing. There's not any kind of uniformity worldwide, but there is good data now that the way that propofol is being manufactured, that there's no risk of any allergy due to the vehicle. Okay? Make sense? All right. Let's go back to page 164. So under generic propofol, I just wrote in there, watch for formulations containing sulfites. And needless to say, because of the lipid emulsion, the propofol does burn on injection. Many clinicians try to do something about that. They may inject a little lidocaine through the IV, a couple mLs, no epi in it, of course, just to numb up the IV site. And then before they give propofol, it doesn't burn as much. Some people put lidocaine in the solution of propofol, so it's propofol mixed with lidocaine. That's not a good idea since you're not supposed to mix anything with it and can possibly contaminate it. For those of you, or us, I've had it too, who've had propofol, you know that this is what happens. Oh, I feel my hand burn. Then you sleep. So, that's about as long as it lasts. So, yeah. And believe me, you won't remember when you wake up. So, it's like, oh, I feel burning. Okay, next drug is ketamine. Ketamine dissolves in aqueous solution. It's not a problem, so there's no burning on injection. And then dexmedetomidine, same thing. It's soluble in water, and although they do mess with the pK and pH a little bit, it still is not a problem, and so there's no burning on injection. So that's a little bit about all the induction drugs and the vehicles and so on. Any questions about any of that? Okay. Now, going to page 167, so I'm going to start going through some of this 1 through 11, my classification. These are IV induction drugs, we call them that. They're also, the real world calls them IV sedative hypnotics, of course, they're the benzodiazepines. And ketamine is the only drug, IV, that's listed as an anesthetic. So that's actually classified by the FDA as an anesthetic, the only IV drug that's classified as such. We went through the history for a lot of it. I'll forget that. Talk about structures, I did that, and I'll do it a little more later. The kinetics we went through with that table, so that we did that. And then preparations and doses. Well, here's the doses, and I have them listed here: Etomidate, propofol, ketamine, There's a separate table. We're going to talk a lot about it next week, a whole big thing about dosing. There's Dexmedetomidine and, of course, Versed. On the next page, I put another table that has doses in there. And needless to say, you got to learn these. Because you go in the OR, and the first thing somebody's going to say to you is, how much are you going to give? And you're going to go, well, I don't know. And then you're going to be in trouble. So you got to come up with a number, right? You can't say 1 to 2 milligrams per kilo. Pick one. You got to commit to something. Right? So come up with a dose. Somebody says propofol, this patient's 50 kilos, you're going to give 2 milligrams per kilo, you're going to give 100 milligrams. Right? So you got to be able to say a dose. So you got to learn these. For propofol, we generally stick to 2 milligrams per kilo. I'll talk a little bit about dosing as we go along this week. Etomidate, usually 3.3 milligrams per kilo. It comes in 20 milligram vials. So if you're a 70 kilo patient and I'm giving you 0.3 milligrams per kilo, then 3.3 times 70 is what? 21. It comes in 20 milligram vials. So just give a 20 milligram vial. You can round it off. We don't do exact here. We round. Valium and the Ativan we don't use for induction anymore. There are some doses listed, but we don't care. Versed we strictly use as a sedative preoperatively, anywhere from 1 to, Lord knows, occasionally all the way up to 4 milligrams, but it's not common. Usually 1 to 2 milligrams. You don't want to make them too sleepy because then you got to wake them up later on. You can have it lingering. Ketamine, there's a lot of different doses, and we're going to talk specifically about that. I have a whole page on that later on, so worry about it. And then dexmedetomidine, loading and maintenance. You give a mic per kilo infused over 10 minutes for loading, followed by 0.2 to 0.7 milligrams per kilo per hour for maintenance. Many, if not most of you, have already used Precedex before. So. There's the onsets. You notice the onset of propofol and etomidate. This textbook listed it as less than 30. Ketamine's a little slower, and the onset's about 60 seconds maybe, even maybe up to 2 minutes. We consider that slow. When you consider that the other ones are taking 15 seconds, when you have to stand there for a minute and a half, that's like 7 or 8 times as long. And you're looking at the clock and you're tapping your foot and you're wondering what the hell is this patient never going to go to sleep. You know? And then dexmedetomidine is a little slower as well. There's the duration of action, and they're mostly due to redistribution. Excitatory activity. Let me stop and talk about this for a minute. You're going to see this listed with a lot of induction drugs. They call it excitatory activity as a kind of a generic catch-all term. What it is myoclonia. All right, so here's what happens. It happens especially with etomidate. And you see there's a 3+ there. So here's what happens. You give somebody 20 milligrams of etomidate to go put them to sleep. You're waiting for it to hit. How are you going to wait, 15 seconds, 20 seconds, whatever. And then all of a sudden you notice the patient twitches a little bit. They kind of have involuntary muscle movements. Are you ever almost ready to go to sleep and your eyes are closed and you're just about ready to doze off, and all of a sudden your leg jerks or something? You didn't do it on purpose. You just kind of did it, right? Or your arm or something. That's myoclonia. They're involuntary muscle movements. And it can happen with the induction drugs because as they go through the signs and stages, if they're going to go through an excitement stage, it's only going to last seconds. But sometimes they can be the point where their inhibitory is inhibited before the excitatory, so they get some muscle, twitches and so on. Excitatory thing. It only lasts a second or two. It scares the OR nurses usually if they're sitting there, all of a sudden the patient's legs twitching, They're looking at you and they say, it's fine. So that's what they mean by excitatory activity. It's because of uneven, the textbooks say it this way. It's because of uneven distribution into the CNS when the patient's going to sleep. So one part of the brain went to sleep a few seconds earlier than another part, and it caused your muscles to twitch.
Is there any correlation with orexin?
Not that I know of. Etomidate seems to be the one that does it the most. So you don't do it. I mean, you just stand there and look. Oh, isn't that interesting? Because 3 or 4 seconds later, they're going to be sound asleep. So it's one of those kind of things to note. All right. Then there's injection pain, and we went through that already. Propofol is the most painful on injection, and the other ones with organic solvents in there generally tend to burn a little bit too, because the solvents do. The more water-soluble ones, Versed, Ketamine, and Precedex, do not burn on injection. Okay? Now, mechanism of action, we already know that. We went through that, number 6 on page 168. Propofol, Etomidate, Benzodiazepines are gabapentin. Ketamine is a blocker of glutamate and MDA receptors. And Precedex is a presynaptic alpha-2 agonist. Okay, now page 169. Next, let's go through some of the generalized effects of the drugs. And for this, let me just, let's skip a page and go to this drawing here first. Page 170. Put several tables in here, I don't know, probably did overkill. But here's one. And this shows you the CNS effect. So this is CMRO2, cerebral metabolic rate of oxygen consumption. This is cerebral blood flow, all of our favorite things we're interested in, right? And what do you see? This is going down, minus percent change. This is going up. So all the induction drugs decrease CMRO2. They put the brain to sleep. Doesn't need as much oxygen. That's a good thing, right? They all decrease cerebral blood flow. Well, if they decrease cerebral blood flow, what do they do to ICP? Make it go down, right? Except what? Except ketamine. So look at ketamine. Went the wrong way. For reasons we'll talk about. All right, go to the next page, 171. This is a table, I think this is out of my book. I took it from Dr. Hemming's textbook, and this summarizes a lot of drugs. This will give me a chance to go back. So these are the gases, of course, cerebral blood flow, and we know the gases make cerebral vasodilation, they increase cerebral blood flow, they decrease CMRO2, so therefore they can increase ICP if you don't mildly hyperventilate. We went through all that, right? Remember that from the gases? Kind of. All right, here's the induction drugs. Etomidate, propofol, ketamine, benzodiazepines, and Dex. What happens? Cerebral blood flow goes down, CMRO2 goes down, ICP goes down except for ketamine. This makes them all go up. So they all decrease all the brain functions. CMRO2, cerebral blood flow, ICP, that's a good thing for all of it, except for ketamine. Makes it go up. See that? And then the opiates we're going to study next, and they're kind of plus minus. You see they zero down, and they're kind of non-committal. They don't do much. So for the CNS effects, you can say this. They all put you to sleep. They're anesthetics. They produce amnesia. The best amnestic drugs currently marketed are the benzodiazepines. That's one of the reasons why we give Versed to everybody. We want to make them a little bit sedate, a little less anxious, and we want them to forget, so they don't remember us later on. The best drugs to produce an amnestic effect are the benzodiazepines. Versed will produce amnesia in about 75 to 80% of the people you give it to, at least 2 milligrams. That's pretty good. Not everybody. Well, you could get everybody, but you'd have to give them so much you couldn't send them home. But in the average 2 milligram or less dose, you'll get amnesia in about 75 to 80% of the patients. Most studies show that. And that's pretty good. They'll all produce, and they'll all have an anti-anxiety effect, and most will be sedate. They'll close their eyes when they're left alone, but they're arousable when you talk to them, shake them in the arm or whatever, they'll open their eyes. So they're sedate, they're anti-anxiety, and they're amnestic. Now, I'm going off on a tangent. There's 2 types of amnesia that a drug can produce. There's 2 types of amnesia. One is called retrograde, one is called anterograde. This is real simple. Retrograde or anterograde. I go into pre-op holding. I got to put an A-line in you. For some godforsaken reason, I decided to do it before I put you to sleep. You're just going to take me too long or whatever. So I give you have an IV in. I give you 2 milligrams of Versed. Then I put the A-line in. Then I go back the next day and find out, did you remember having the A-line put in? All right? Or, let's say scenario number 2. I go in, and I don't give you the 2 milligrams of Versed. I just put the A-line in. Then I go, oh, I forgot to give the Versed. And I give it after the A-line goes in. So I did the painful procedure first, then I gave a drug and tried to wipe the memory of it out. All right? Rather than giving the drug, the patient it's already on board, then doing the painful procedure. Okay? Now, retrograde amnesia is the situation where I did the painful procedure, then I tried to give a drug to wipe it out. Retrograde, back, looking back, right? I'm trying to get amnesia for something that's already happened. I'm trying to wipe out your memory of it after I did it. Retrograde. Anterograde amnesia is I drug you up, and then I do the painful procedure, and then hopefully you won't remember. That would be doing the procedure going forward in time. Anterograde, right? Which one do you think is going to be easier to produce? Anterograde, sure. You get retrograde amnesia with Versed, but it's not reliable, and it's not a high percentage, 20, 30%. Anterograde, you're up 75, 80%. So it's better to give the drug first and try to produce anterograde amnesia than it is to try to wipe something down later. Make sense? Okay, all of them generally have an anti-seizure effect, or benzodiazepines especially, but propofol and Etomidate as well. Ketamine does not. All the GABA-mimetic drugs tend to be anti-seizure. They also have a sinus effect where they have a neuroprotective effect in the brain. It's not real clear what it is, how much to give, but nonetheless, they seem to have at least some neuroprotective effect. You know, for many years, for decades in fact, we've put people into barbituric comas, brain injured patients, put them into a coma with the idea that if they can keep their brain asleep, doesn't need as much oxygen, doesn't require as much metabolism and so on, and then allow some recovery and repair, let the brain recover a little bit and bring them out of the coma, that they would have a better outcome, and it doesn't work. We still try it, and it's not a bad idea to try it, but so far there haven't been any studies showing there really is a benefit over in the long run, but we gotta try something. I guess it's not a bad thing. Alright. Good. Next, I'm on page 172. The anesthetic effects on cerebral hemodynamics, measured by a Doppler, transcranial Doppler. And they're just showing that autoregulation tends to be preserved. The brain's still going to be able to shunt blood to where it needs it, autoregulate with your blood pressure, all the good things we want the brain to do. They all seem to be preserved when you use these IV induction drugs, not so much with the gas anesthetics. And their reactivity to CO2, in other words, if you have carbon dioxide increases, you have cerebral dilate. If you hyperventilate, you cerebral constrict. So their cerebral activity is preserved, except for dexmedetomidine, which it tends to be blocked. Okay, cardiovascular. Let's do this a little bit, and then I'll call it a day. Call it a week. Let's talk cardiovascular. This is real simple. I want to say it now, then I can repeat it next Thursday when we meet again. And here's the way it works. This is the way everybody in the world gives the anesthesia. It's real simple. You don't even have to write it down. I wrote it for you in the book. But anyways, here's what happens. If you go in to see a patient, they got an IV in, you put them to sleep with propofol. That's number one. Done. Why? It's rapid, it's pleasant, patients like it, they wake up with some euphoria, it's got antiemetic effects, we'll talk about all this next Thursday as we continue on, but it's got some great properties. It's got a short half-life, the patients wake clear-headed, they don't have a hangover, you can send them home, all the reasons why we like propofol. All right, so we give it unless there's a reason not to. In kids, of course, with an IV, we do a mask induction. But that's obviously a niche. We're talking about peds. But in most older children, any older children or adults, then we're going to use propofol. Propofol is the most cardiac and respiratory depressing of all the induction drugs. It's the one that causes your blood pressure to go down the most. So, if you have a patient where you're worried about their blood pressure, you got some little old guy, and he's kind of beat up, and he's got a bad heart, and he's not the best nutritionally, and he's got diabetes, you get the point. Somebody that's a little bit ASA3 kind of patient, and you're afraid if I give him propofol, I'm going to turn around and my blood pressure is going to be 40, then we go to plan B, less propofol. If you're afraid that even less propofol is going to be too depressing, then we switch to Etomidate. So we only use Etomidate when we can't use propofol. Etomidate is less cardiac depressing, but it still is a little bit. If they're so sick you can't even give them Etomidate, let's say they're in shock, they come from ICU, they're on drips, and they're just about trying to die. Thus they have this operation where you're saving their lives. You can't even give them Etomidate because they'll have no blood pressure. They're already on a dopamine drip or a Levophed drip or whatever. Then we use ketamine. So our choices are propofol, less propofol, Etomidate, ketamine. That's the way everybody gives anesthesia. I promise you. There's not one thing I can say that what everybody does, but that thing everybody does. That's the way we go at it. For reasons we'll talk about Thursday. Okay, I'll quit. Have a nice weekend.